and renal disease progression, as well as in dialysis patients, such as bone and mineral bone density or disorder, sorry, bone and mineral disorders, which is the topic of today, as well as the cardiovascular risk factors. His scientific work encompasses more than 390 original papers, reviews, and editorials, and 40 book chapters. So without further ado, we welcome Professor Flogo today to discuss with us the management of secondary hyperparathyroidism in dialysis patients. So, Professor?
Thank you so much, and it's a pleasure being with you again, even though it's only virtual. I would have loved to be physically there rather than in my living room. So today we will discuss secondary hyperparathyroidism, and what you see down here is my hospital. It's an unusual hospital, you can tell from the architecture. But it's also unusual because my city called Aachen, this is where Germany was founded, it's located right at the Dutch border, and the trees you see in the back of this photograph are already in the Netherlands. And I can also see Belgium from my office. So I probably have the only nephrology office where I can see 3 countries from my window. So what do I want to do today? Let me just get settled. Okay, so these are my disclosures. And I would like to start the discussion with data that we obtained in the ARROW initiative. Now, the ARROW initiative is an analysis of the European Fresenius database. So all the Fresenius centers in Europe, they have a common database. And here we looked, where's the lowest mortality risk defined by a hazard ratio of below 1.1. And it turns out that it's at a serum phosphate in these hemodialysis patients of 1.41. With a wide confidence range, but you can see that no matter how we correct, mortality increases when you go into hyperphosphatemia, and it increases at low phosphate. And note that these 2 lines here are corrected for albumin, so it's not malnutrition. This is calcium. Note the lowest mortality is at 2.16. And there is no lower limit. This is the interesting finding, whereas if you go into hypercalcemia, the risk of mortality increases very quickly. So it's very much in line with the latest KDIGO guidelines. And finally, here is PTH. The lowest risk is at a PTH of 471, and the confidence range 260 to 720 is very similar to the KDIGO target range of 2 to 9 times the upper limit of the assay. And you can see here it's bad to have a suppressed PTH, and it's bad to have a very high PTH. So what I've done, and this is how I will structure the lecture, is I've asked myself, where do we have convincing evidence from randomized clinical trials? And I'm stressing the clinical here, suggesting clinical benefit. And this is important to stress. We have lots and lots of data on biochemistry, but very little data on clinical benefit. And I've roughly grouped the evidence as none, the gray boxes. We would love to have many red boxes. We have definitive evidence that high phosphate is bad. And orange, we have some evidence, but it's not definitive. Now, if you ask yourself, what do you do first in secondary hyperparathyroidism? I guess we would all agree that step number 1 is to control serum phosphate. You can do this by diet. And note that this is a gray box. It has never been shown that restricting phosphate in the diet is beneficial or that it's even safe. You could just as well make the point that if you really want to restrict phosphate in the diet, you will inevitably induce malnutrition. We have some evidence that adjusting dialysis, good dialysis, means good phosphate. And we have some evidence for phosphate binders, in particular for the choice between calcium-containing phosphate binders and sevelamer for historical reasons. And we have very little evidence for the newer phosphate binders. Step number 2 usually is vitamin D. Now here's the evidence that vitamin D is something beneficial. It's zero. It is absolutely zero. There has never been a study showing that calcitriol, alpha-calcidol, paricalcitol improve clinical outcomes. Nor has there ever been a trial with native vitamin D. And this is something to keep in mind. We are all doing this, and I'm doing it. And I've been doing this for the last 30 years, and we have no evidence that we're doing something good. Step number 3 would be the specific intervention. This could be parathyroidectomy. No doubt, if you have a PTH of 3000 and lytic bone lesions, brown tumors, and pains and fractures, a parathyroidectomy is a good thing. But this is only true for very rare patients of mine. We have some evidence that cinacalcet affects clinical endpoints, and I will come to this. And Etelcalcetide is too new to have clinical evidence that it's beneficial. There's also been a discussion, because there is so little evidence in the vitamin D role, well, shouldn't we really change the steps and have calcimimetics go before we think about vitamin D? And it's only for cost reasons that this is still as it is. So I don't want to go into basic studies. I want to cover the very recent studies that were presented at the congresses or just published. So we have new options for treatment of hyperphosphatemia. One very interesting option is a substance called tenapanol. It's a sodium proton pump inhibitor. So it was never meant to lower phosphate. It was meant to excrete sodium into the intestine and to get rid of sodium in dialysis patients. And just accidentally, they discovered that as you lose sodium into the intestine, you also lose phosphate, probably by paracellular secretion of the phosphate. So this is important to stress. In the case of tenapanol, it's almost impossible to separate the excretion of sodium, and that inevitably means inducing diarrhea, from the excretion of phosphate. So here's the phase 3 trial. They've used patients, washout period, then added increasing doses of tenapanol, and then they went back to placebo or pooled tenapanol. This is what happened. With tenapanol, the serum phosphate decreased by about 0.33 millimoles per liter, so that would be a milligram per deciliter. And as I said, you cannot separate it from the effect of the drug. The bowel movements per day increased by about, I don't know how you have half a bowel movement, but it increased. So that is one option. The other interesting substance is an old one, nicotinamide. Here's the combined trial, nicotinamide combined with lanthanum carbonate. Nicotinamide blocks most intestinal phosphate transporters, because if you give a phosphate binder like lanthanum carbonate, the intestinal wall will sense, oops, the phosphate is low. I should increase my phosphate transporters. And that you can block with nicotinamide. However, in these 205 patients with a GFR of 30, adding nicotinamide to lanthanum was no better than adding placebo to lanthanum. So here it didn't really work. The other trial that has been going on is nicotinamide as add-on to phosphate binder. It was tested in Germany using various phosphate binders in Poland. And the data have not yet been published, but this combination here is a little more potent than a phosphate binder alone. And I'm stressing a little more. It is not dramatic. It is not 0.3 millimoles more potent like the tenapanone. It is just a little. Phosphate binders and mortality of dialysis patients. This is, of course, the key question. And it's fascinating that in the year 2020, we still discuss this. We've been using phosphate binders for the last 50 years, and we still don't know for certain whether it affects mortality. So this is the landmark trial. It was presented 2 years ago at the American Society of Nephrology, 270 Japanese dialysis centers. And they randomized their patients to lanthanum carbonate, a maximum of 2,250 milligrams per day, or to calcium carbonate, 3,000 milligrams per day. These were the target ranges. And this is important to stress because Japan has very funny target ranges like no other country in the world. So their target PTH is low. This is what they found. The probability of cardiovascular events, it was more in the lanthanum group than in the calcium carbonate group. Very frustrating, because we would all believe that going calcium-free is better. So at least in Japan, the word is still out, what is the better phosphate binder? How about cardiovascular calcifications? I will just briefly comment on 2 trials, a Danish trial on magnesium and a Japanese one on magnesium. Now, for the Danish trial, you need to understand what is the T50 assay. This is an assay that we have developed, which essentially measures how good is your serum in inhibiting calcium and phosphate precipitation. So it measures the inhibitory effect of serum on calcium phosphate precipitation. Normally, if you have calcium and phosphate in water, you add the calcium and you see that 60 seconds later, everything has precipitated and you get a solid precipitate that simply settles down. If you do the same in the presence of your or my serum, you can see that it gets cloudy. And it gets even more cloudy here, but you never have a precipitate of crystals. So you can now calculate how good is your serum to go from a little cloudy to very cloudy. And you can calculate what is known as the T50, the half-life, the minutes where 50% of your solution gets very cloudy. And this is a very good reflection of how good is your serum in inhibiting calcification. So what has happened here? Here you see what is now known as calciprotein particles. You have to consider this. It's a bad thought that you and I, when we have eaten, we all form crystals in blood. And then comes things like fetulin and other proteins, and they take up the crystals like a lipoprotein particle, and they remove them. And it's only if you wait long that you get real crystals. So this is what is known as secondary calciprotein particles, and they really make the solution cloudy. So this is what you don't want to have. So the T50 assay, as I said, measures when do primary calciprotein particles turn into secondary calciprotein particles, and what is the half-life until then. We know that this assay is affected by calcium and phosphate, but on the other hand, it's affected by pyrophosphate, which inhibits calcification, fetulin A, albumin, magnesium, and other inhibitors. And this is what the Danish group has tested. They have increased the dialysate magnesium to 1 millimole. So these patients were randomized to 1 or 2 millimoles. And then they looked at the calcification inhibition. So when you do that, the serum magnesium of your patients increases, and you can see nicely that the serum is more potent in inhibiting calcification. The Japanese have tested this in a clinical setting, starting with the fact that magnesium interferes with calcium phosphate crystal formation, and that experimentally magnesium can retard progression of calcification. And as I just showed to you in this Danish study, increasing magnesium intake, or in this case, intradialytic exposure, improves the calcification inhibition of serum. They did a randomized controlled trial, and actually the trial was meant to test a compound called AST120. Think of this as charcoal. It didn't work, so I will not comment on it at all. But they had another group receiving magnesium in there. So I will focus on this comparison, magnesium versus control. And they gave 330 milligrams of magnesium, and they measured the serum levels so that no hypermagnesemia developed. What they found is that serum magnesium increased a little bit, but nothing else. In particular, PTH was not suppressed. This is a common concern when you give a lot of magnesium to dialysis patients, that you suppress the PTH. And the GFR in these patients was stable around 30. This is what they found. In the control group, the coronary artery score increased, the calcification score increased by about 50%. And this was also observed if you had a high pre-existing burden. In the total population, and no matter whether you had a lot to start with or little to start with, there was essentially no change in the whole group. And the calcification in the coronaries did not progress. Interestingly, in the thoracic aorta, there was no difference between the two groups. So this is something that at least I don't understand, why in the coronaries magnesium inhibits calcification progress, but not in the thoracic aorta. The key side effect of adding magnesium to the diet in these patients with a GFR of around 30, well, it causes diarrhea. But that was the key side effect, nothing else. So let me now, after discussing phosphate binders, let me talk a little bit about new data on vitamin D. We have one large trial which was presented at last year's EDTA Congress, the VITALE trial. It was high dose versus minimum recommended intake of vitamin D3 in kidney transplant recipients in a French multi-center trial. And they have given a lot of vitamin D. So these were patients 1 to 4 years after transplantation. They were all vitamin D insufficient, so their 25 hydroxy vitamin D was below 30. And they were randomized to 12,000 units of native vitamin D every other week, so the equivalent of 800 units per day, or they were given 100,000 units, so really a lot, 6,600 units per day, and then during follow-up reduced to half of the amount. The composite endpoint was cardiovascular events, diabetes, cancer, death, transplant failure. It worked nicely. This is serum 25 hydroxy D3 levels. The low dose group stayed around 20 to 25. The high dose group increased from 20 to 46 and then stayed high-ish. So they nicely separated the two groups. This is the frustrating slide. Even if you give these very large doses for 2 years, there's no difference in major cardiovascular events, diabetes, cancer, or death. Very much in line with the American VITAL study in a large cohort of normal people with no kidney disease. There were also no differences for infections, rejection, calcium or phosphate, calciuria, or blood pressure. There was only a drop in the PTH from these mega doses, and if you look at this, with very, very, very high native vitamin D, you have some suppression, but look at the scale here. You go from 95 to 85, so it's not a lot. But fortunately, there was one positive result, and that cured my picture of the world. The fractures were lower. 12 fractures in the low dose group, 3 fractures in the high dose group. And this was highly significant. So the take-home message from here is that vitamin D does what we believe it does. It's good for the bone, but probably not a lot for anything else. So for me, this is a nice support of why I continue to take my vitamin D every 7 days. And now we come to specific intervention. I will not talk about parathyroidectomy. There's no new data on this. It works, but you go into a hungry bone, and unless you have a good surgeon, you may end up without PTH, which is a terrible situation. But let's go to Cinecalcet. This is the MIMOSA study published last year. And what they have asked here is, so if my PTH is at various levels, 700, 850, 950, or above 1,000, how in the next year with Cinecalcet therapy, how would my PTH do? So if you look at the highest group first, you are above 1,000, you give a calcium mimetic, and it hardly works. You probably come too late. Probably these parathyroid glands have lost their calcium sensing receptor and are relatively resistant to Cinecalcet. Orange group, it decreases very slowly and it takes a lot of time to decrease. Gray group, it decreases somewhat and then it increases. Green group, You start at 730 and it continues to fall. So the insight from this study is, don't wait until your PTH is 1000, because then it's likely too late. Start when your patient has left the KDIGO target range and try to bring it down before it becomes autonomous. The latest addition is Etelcalcetide. Now, Etelcalcetide is very different from cinacalcet. Cinacalcet is a small molecule. Etelcalcetide, on the other hand, is a short peptide. So Etelcalcetide can only be infused, and you can only use it in hemodialysis patients. If I receive Etelcalcetide, I excrete it via my kidneys in minutes. So you need to be a hemodialysis patient for the use of Etelcalcetide. This is the so-called head-to-head trial. Etelcalcetide compared to cinacalcet, and the readout were biochemical parameters. Now, Etelcalcetide is also different from cinacalcet because of its half-life. So you can estimate that a single injection of 5 milligrams of Etelcalcetide at the end of dialysis will rapidly induce a decrease of PTH, and then it can take up to 70 hours for the PTH to come back to normal. So if you infuse Etelcalcetide, you should not measure PTH in the next day, because it will be low because you have simply infused Etelcalcetide. And it would go on then. So this would happen then if you repeatedly at every dialysis session inject 5 milligrams of Etelcalcetide. This would happen to the PTH. Now let's have a look at cinacalcet. This is what cinacalcet would look like. You take a pill of cinacalcet, it drops, not as much as with Etelcalcetide, goes up again, you take the next pill the next day, it drops, take the next pill, it drops. So unlike Etelcalcetide, you have much more rapid swings here of the PTH. Whether this has the same effect of bone, this slow swinging, or this much more rapid swinging, we don't know yet. And I hope that one day we will have a bone biopsy study to look into this. This is from the head-to-head study. They both started at a comparable PTH. The cinacalcet group, after about 12 weeks, stabilized at about minus 400. The Etelcalcetide is more potent, and you can see that it goes down further than the cinacalcet, even though you were allowed in this study to increase the dose of cinacalcet. Adverse events. Well, here's the bad line, and this was frustrating. We had all hoped that the major side effect of cinacalcet inducing nausea would not be there if you give it as an infusion. And in the head-to-head study, there was no difference between the two arms. But I was part of the head-to-head study, and I know how it was done. Every day, the patient had a small iPad, and every day, they were asked, are you nauseated? Are you very nauseated? Did you vomit? Now, conceivably, if you're asked every day, are you nauseated? You finally admit it. Yes, you are nauseated. And I will come back to this. So here's an integrated analysis of all safety data of Etelcalcetide that were published until 2019. And the conclusion is the safety is similar to cinacalcet. The most important risk is calcium reductions and hypocalcemia. And again, I will come back to this. How about real life data? Here's American data from US renal care centers, 1,100 patients who initiated Etelcalcetide. And first of all, you can see that the majority of patients initiated Etelcalcetide with 5 milligrams given 3 times per week after dialysis. And then you can see that as you go over 6 months, much fewer patients have 5 milligrams. Many more have only 2.5 milligrams. Others, in turn, need more than 10 milligrams. So it really is like a fan opening up. This is PTH. So PTH was controlled below 600 blue in 40 patients at month -3 before the switch. 30% had a high PTH, 28% a very high PTH. As you get closer to the switch, 40% now are very, very high, 40% are uncontrolled, only 19% are in the target range. And you can see that this increases to 51% controlled, and that these amounts here are very much lower. Portugal, 3 Portuguese Davita clinics, and these were patients very, very difficult. PTH above 800 despite cinacalcet. And look at this, a median of 180 milligrams per day. So the doctors were desperate to get the PTH down, and they gave the maximum dose, and it didn't work. And then they were switched to Etelcalcetide. And look at this, calcium decreased, phosphorus decreased, and PTH came down from 1,000 to 700. So the immediate explanation is obvious. What did the patient do with cinacalcet? Well, it probably ended there, and it wasn't taken. So that's one of the big benefits of Etelcalcetide, that you inject it. You know it's there because your nurses inject it. Here's a multi-center real-life study from Spain. They were switched to Etelcalcetide or received it de novo because of inadequate PTH control or a high pill burden, but I think that's a minor argument. Most had an inadequate PTH control. They started with around 5 milligrams, 6.4. This had to be increased. The PTH went from 500 to 320. The calcium dropped, the phosphate dropped. So just what we would expect from a very potent calcium mimetic. And this is the most interesting finding. It's very consistent in all the real life studies. Whereas the head-to-head study had said nausea and vomiting is just like with cinacalcet. And remember, they had an iPad, asked every day, are you nauseated? In real life, nausea and vomiting doesn't seem to be a problem with Etelcalcetide. Symptomatic hypocalcemia, nobody. Asymptomatic hypocalcemia, 4 cases. No other adverse events in this Spanish multicenter trial. And finally, a Japanese study. Real life data. Prior cinacalcet dose, the Japanese have lower doses. It was more than 50 milligrams per day, and you can see for Japanese standards, remember they have a different target range. By Japanese standards, this is a very high PTH, and it came down. If you had no cinacalcet before and you start Etelcalcetide, it comes down. If you have a little bit of cinacalcet, it comes down. So it works everywhere in the world. And again, that's important. Hypocalcemia Another interesting observation. So the most hypocalcemia was observed in the patients who had no cinecalcet before they started etelcalcetide. And that's logical, because when you have a very high PTH and you start a calcimimetic de novo, you have something like a hungry bone syndrome. No patient had GI side effects, even in Japan. And a final piece of evidence, again from Japan, they looked at parathyroid gland volume. So if you just look at this row, the total gland volume, it evolved in the year 2015, 900 cubic millimeters. In March 2016, 1,515 cubic millimeters. And then they switched to etelcalcetide, and look at this. It decreased to 82 from 1,570. It took almost a year to do so, but it's a fascinating decrease. So etelcalcetide not only reduces PTH, it also reduces parathyroid hyperplasia. What about the hypocalcemia that I have mentioned repeatedly? Here's a study that we did based on the EVOLVE trial. In EVOLVE, we had tested cinecalcet versus placebo to control secondary hyperparathyroidism. And what we noted is every dot, every little bar here is a hypocalcemia event. So what we had seen is that any hypocalcemia defined as a serum calcium below 8.4, if you measure in millimoles, divide by 4, so it would be 2.1 total calcium millimoles per liter. If you look at that, something like 70% of the cinecalcet patients developed hypocalcemia. In the placebo group, it was 20%. If you now look at severe hypocalcemia, it was about 20% in the cinecalcet group and something like 5% in the placebo group. The predictors were severe hypocalcemia, so below 7.5, was more likely in patients from Latin America and Russia. This sounds strange initially, but it's logical. The patients from Latin and America and Russia who entered the trial were mostly young, very young, compared to the rest of the world, and they had a much higher PTH. So as I said, if you start a calcimimetic at a very high PTH, your calcium will drop very quickly. So this confirms that high baseline PTH is a predictor of hypocalcemia. High bone turnover is a predictor, and low baseline calcium is a predictor. High body mass index, we still don't really understand why that is a predictor. So the take home here is if you have more severe secondary hyperparathyroidism at trial baseline, you're more likely to go into hungry bone syndrome. Don't wait too long, start the calcimimetic earlier. And then one of the reviewers asked an interesting question. What happened after severe hypocalcemia? What did the doctors in the trial do? And you can see that the most common response to hypocalcemia was no change. They didn't care. Some even increased the cinecalcet dose, which doesn't make sense at all. So you have hypocalcemia and you ignore it and you still increase your cinecalcet dose, which tells you that this is a relatively harmless and safe situation. Another reviewer question was really interesting. What does PTH do when you go into hypocalcemia? If you and I go into hypocalcemia, my parathyroid gland will sense hypocalcemia and PTH goes up very, very quickly, very quickly. Now, if you have cinacalcet on board, look at this, in the severe group, prior to hypocalcemia PTH 500, at the hypocalcemia 465, and now it should shoot up because you're hypocalcemic. Instead, it goes down further because the parathyroid gland cannot respond to the hypocalcemia by releasing PTH. Cardiovascular events we looked at in the arrow cohort. Is hypocalcemia dangerous? These are patients who had a hypocalcemia event, and we looked for 12 months after cinacalcet. And what you can easily see is that compared to patients who had no hypocalcemia after cinacalcet, no difference. If at all, there were more sudden cardiac deaths and deaths in the group with no hypocalcemia. So the take-home message here is that even though hypocalcemia develops and is severe in some patients, it doesn't seem to cause clinical consequences. On the opposite. And this is why the KDIGO guidelines now say that some degree of hypocalcemia seems tolerable, acceptable. Safety, hypocalcemia with Etelcalcetide. Well, here you can see that in the head-to-head study, severe hypocalcemia was similar in terms of prevalence, even though the mild hypocalcemia was more common with Etelcalcetide. It is just a more potent calcimimetic. And finally, bone. What does bone, at least biochemically, do? Well, if you look at Etelcalcetide versus cinacalcet, Etelcalcetide lowers FGF23 more, bone-specific alkaline phosphatase more, and bone turnover more. And if you look, what do calcimimetics do? Well, a phosphate binder will lower phosphate, will lower a little bit of PTH, will lower a tiny little bit of FGF23. Native vitamin D has very little effect, as I showed to you. Calcitriol paricalcitol will increase calcium, increase phosphate, decrease PTH, but increase FGF23. A calcimimetic is the only compound we have today which will lower all of these four parameters, which we believe is not a good thing to have. And we believe it because this is an analysis we did several years ago, again from the EVOLVE study. We asked if you have with cinacalcet a 50% reduction in FGF23, what is the clinical consequence of that? And what we found is that the patients who experienced a 50% reduction in FGF23, they had much less cardiovascular mortality, and they had a huge, almost 50% reduction in cardiovascular sudden death. And interestingly, they also had a 50% reduction in heart failure events. So it's good to be in the group where the FGF23 falls. What about cardiac hypertrophy? This is an ongoing trial, and I suggest you watch out. It's for this one. It's going on in Austria, and here they compare alpha-calcidol to suppress PTH with Etelcalcetide, and they do cardiac MRI scans, and hopefully next year we will see the data. So I'm coming to the end. What did Flöge say? I think that CKD, MBD, KDIGO target ranges, I hope I convinced you. In dialysis patients, the target ranges are confirmed and supported by epidemiologic data. Lowering phosphate, there's a potential role of tenapanor once it comes, this sodium proton pump inhibitor. I'm skeptic whether nicotinamide will make it. The effect, if at all, is modest, but companies are working on intestinal phosphate transport blockers. And frustratingly, in the landmark trial in Japan, lanthanum carbonate was no better than calcium in terms of mortality. Vascular calcification, increasing dialysate magnesium improves the capacity of serum to inhibit calcification, the T50 test. Supplementary oral magnesium in CKD3/4 retards coronary, but not aortic calcification. Native vitamin D, high doses reduce fractures, but nothing else. But that's enough. That's what I want to have. Calcimimetics, don't start too late. Remember that you become resistant. Etelcalcetide, very potent IV mimetic, mostly used at 5 milligrams after dialysis. Similar GI side effects in the head-to-head trial, but very few GI side effects in real life. It lowers potently FGF23 in contrast to calcitriol, paricalcidol 1-alpha. Calcimimetic-induced hypocalcemia, it's frequent, it's rarely severe, and the most frequent intervention and outcome, none, don't care. Spontaneous resolution, and it doesn't really seem to have clinical consequences. So I hope I have updated you with the latest in secondary hyperparathyroidism, and I'd be happy to take any questions. Thank you for listening to me.
Thank you, Prof. Flogo. This was a very nice session. So now we open the floor for questions. I have a question here from Dr. Mu'taz. His question is regarding the point of parathyroidectomy. So he's asking, is there a point that no benefit can be predicted from doing parathyroidectomy or not?
Well, one very good test is to give a calcimimetic. If your PTH is 2000 and you give a calcimimetic and the PTH doesn't move, then your parathyroid gland has lost all calcium sensing receptors and it needs out because you can no longer control this parathyroid gland. I would also consider reducing phosphate. Phosphate is a very strong stimulus of PTH. So if your PTH, if you reduce phosphate and the PTH doesn't move, take them out. I don't think there's any absolute level. Of course, at 2,000-3,000 PTH, I would get nervous. I can no longer treat this.
Another question from Dr. Muhammad Ahmed. His question, he said he observed marked fluctuation in the PTH level in many patients on cinecalcet treatment, despite the stable calcium, phosphorus, and without change in the dose. So he's asking what could be the reason or explanation for the fluctuation. Yeah.
Well, there are several potential explanations. First of all, what I have experienced is that my lab changed the assay without telling me. That in itself is a good reason. The assays can really differ what they measure. Reason number two is your PTH should be taken on ice. There's a huge pre-analytic error depending on how you store the blood sample. Number three could be that your patient has taken the cinecalcet too shortly before you take the blood. Remember how the PTH decreases quickly after you give cinecalcet? So if you take a blood sample early after cinecalcet, within 8 hours, it would be erroneously low. All of this, these are potential reasons.
A question from me, actually. So the use of Etelcalcetide, we can see now from the head-to-head study, there is a difference in the nausea vomiting. Sorry, there's no difference in nausea vomiting.
In real life. In real life.
Yeah, and in real, but there are some few other studies have shown no much of nausea, vomiting. So is it really a real concern or not? So
Yeah,
my question,
right.
yeah. So my question, if you have patients with nausea, vomiting, severe or I mean significant nausea, vomiting with senecalcet, would you consider switching them to trying Etelcalcetide?
Yeah, absolutely, absolutely. And in my hands, it works. Many times you can use this as a rescue therapy. And as I said, my impression is that what we have seen in the head-to-head trial, that no difference, is not true in real life. In real life, it's less with the injectable.
Sure. Sure. We have one question here about the use of denosumab. When will you consider the use of denosumab in CKD and in dialysis patients? And what indications? Yeah.
It's very potent. I'm concerned, and this is personal experience which made me very cautious. I have seen life-threatening hypocalcemia from denosumab if you give it to patients with advanced CKD, up to the point of cardiac arrhythmias, which became life-threatening. So that's one concern with denosumab. If you give it, make sure your patient doesn't go into hypocalcemia. The other concern, of course, is what happens when you stop denosumab. There's this puzzling observation that the fracture rate goes up quite markedly after you stop denosumab. And nobody at present can really tell you how long you should give denosumab in CKD.
Sure. Another question from, again, Dr. Mohammed Ahmed is asking about the use of senecalcet in patients with anuric indecisional disease versus patient with residual kidney function. So his observation, there is difference in the response of phosphorus he mentioned. Maybe he means PTH. So do you have anything to comment on this?
I don't think there's any data on this particular issue. I think to extend that question a little bit is what do you do in the transplant patient where you have diuresis? And senecalcet, at least in an off-label indication, is used commonly in transplant patients who have recurrent severe hyperparathyroidism plus hypercalcemia. But in the dialysis patients, I don't really distinguish between anuric and non-anuric. It's an interesting observation, but I have not heard this before.
Sure. Another question is about the threshold PTH level for kidney transplantation. So if you have somebody with severe hyperpara, when will you consider it safe to go for transplant?
That's another very good question, an unresolved issue, I must admit. Sometimes it's better to have the parathyroid gland out if there is severe hyperparathyroidism, because it's so common that you give a transplant to these patients and they have recurrent hyperparathyroidism, and then you're struggling with hypercalcemia of the graft. Then you have to reinitiate senecalcet off-label after kidney transplantation. So if it's really severe and if you cannot get the PTH down below 1,000, let's say, before transplantation and you have a scheduled transplantation, I would suggest you rather do a parathyroidectomy if, and here comes the big if you know a good surgeon.
Sure. I have two questions. Both of them are related to hypocalcemia with senecalcet. So the first says, would you consider starting senecalcet if the patient is already hypocalcemic? And the second one is questioning the option of do nothing if there is hypocalcemia.
Right. Well, first of all, in the label, it says you shouldn't start it if your serum calcium is below normal. Full stop. It's a contraindication, formally speaking. I was very surprised to see in a trial, And a trial is, of course, something different than real life. In a trial, that the vast majority, more than 80% of the doctors did not do anything in response to hypocalcemia, suggesting that the hypocalcemia was mostly mild. And I must say, I'm not really concerned when my ionized calcium is 0.9 or 0.85. I simply tolerate it. It will disappear after a while. It's a mild form of hungry bone syndrome. And I've never seen muscle spasms or any consequences of hypocalcemia in these patients. So it's an interesting observation. It's now supported by the guidelines that you can tolerate mild degrees of hypocalcemia. And I'm stressing mild. If it goes below 0.8 ionized, 0.8 millimoles ionized calcium, I will get nervous, I must say, and I would do something.
And so in terms of doing something, will you stop the medication first, or will you add vitamin D or vitamin D analogs? So you have combined treatment.
Yeah, both make sense. I mean, you can hold or reduce cinacalcet. You can give active vitamin D. You could also give more calcium-containing phosphate binders. And I'm saying this because I'm normally afraid of calcium loading in dialysis patients. But here you have a situation where the calcium in all likelihood will go to the bone as opposed to the arteries.
Sure. Okay. There's a question about the direct observed therapy. So giving cinacalcet orally immediately after dialysis while observing the patient. Do you have any experience with this? Because here Dr. Muhammad again is asking this question. He tried this and it worked with his patients.
Yes, but you have to see that the action of cinacalcet is short-lived. So if you give it under observation, which makes sense in many patients, you have to realize that you're only giving PTH for 3 times a week. And I don't think anybody knows what this does. Etelcalcetide, it's under observation because you inject it. So that has a much longer action, and that works to suppress the PTH.
Okay, here is a question about the role of cinacalcet in pre-dialysis patient. I think you talked about this.
Yes.
Yeah.
Amgen considered this, and they quickly dropped the idea. If you give to rats with CKD, so let's say CKD 4 is maybe what you can get a rat into. If you give cinacalcet to that rat, the rat will die. And it will die because it calcifies, it has serious hypercalcemia, and it will die from calcifications. So the standard observation that you have if you give it to CKD 3 or 4 patients is that the phosphate goes up. And that's probably harmful. Now, the situation is opposite when you give it to a transplant patient, because you and I know that most transplant patients have hypophosphatemia. So there, the risk of hyperphosphatemia is much lower. And there, it allows you to give cinacalcet. But I wouldn't do it in a pre-dialysis patient.
Sure. I think this will be the last question. It's about the use of pericalcitol. So vitamin D and vitamin D analogs versus cinacalcet. When will you consider one over the other?
Pericalcitol, to me, I use it very infrequently. If at all, we use calcitriol, and we use low doses, no more than 0.25 micrograms per day. The danger is with pericalcitol, it's potent. It induces hypercalcemia. I'm concerned of hypercalcemia. And I'm somewhat concerned about the FGF23 increase with calcitriol, 1-alpha, and pericalcitol. I'm also concerned because of the OPERA study and the PRIMO study, where 1 year of pericalcitol didn't do anything to cardiac structure, but it did increase serum calcium. So I've become a relative non-user of active vitamin D.
Okay, I think we can conclude by this question. This was very interesting session. Thank you, Prof. Flogo, and we wish we will meet again and have the same subject or other related subject. Thanks a lot, and thank you for all the attendee, and thanks for the Saudi Society of Nephrology as well. Thanks.
Thank you all. Bye-bye.
Bye-bye.